I don't have any disclosures, except that I do want to share what SSMC looks like. It's a beautiful facility east of town here. And if you're ever in the neighborhood, please do come visit us. We like to show off the place. As Dr. Nahida mentioned, I've been here just about 11 months, and my task has been to be the chair of the internal medicine division. And much of my time has been spent thinking about how to build the best practice models for different patient populations. And those patients with psychiatric comorbidities is one that hits my radar often and frequently. And so what I'd like to do during this time together is just share my observations and practice since I've been here, then review potential practice models for inpatients who have psychiatric comorbidity, and then just shamelessly seek your advice as people who practice psychiatric co-management, perhaps with internal medicine teams, in terms of how best to execute care for these patients. So that's our objective in our short time together. Just a fact that gives us some context around this discussion: a third of medical and surgical inpatients have psychiatric comorbidity, and I would say that specific to patients at our facility, that is, although we haven't formally measured it in our division, I think just empirically in practice, I would agree that it's probably around that, at least that high. Another observation I've made is that care in our area and in the neighborhood of our medical center is very fragmented. The concept of primary care per se, people can't identify a single doctor. They will seek care multiple places depending on what that care is that's needed. And care is not standardized. So a lot of my last year has been just standardizing processes around different diagnoses or different patient populations again. So if we could make that the de facto approach to things, I think we will have scored some wins. And then a multicultural population that Dr. Anwar has already highlighted, both patients, but also our bedside clinicians. And so both parties at any interaction at the bedside bring their own language, their own sort of cultural understanding or approaches to all care, whether it's medical care as we describe it, or psychiatric diagnoses as well. So with those observations, I wanted to share, this was interesting. So if any of you are from Al-Ain and published this data, thank you. It was helpful for me to understand in an inpatient population, the diagnoses that are represented in the local area here. So you can see the top three: psychotic disorders, bipolar disorders, substance use disorders for hospitalized psychiatric inpatients. This group also split out the Emirati and expatriate population. You can see the diagnoses represented there as well. And again, just to support Dr. Anwar's observation about how multicultural our patient population is, this is the percentage of those nearly 1,000 patients that were cared for over a 3-year period in Al-Ain and some of the countries that were represented there. Another variable in sort of my decision-making in terms of the optimal model of care for inpatient management of patients with psychiatric comorbidity is this. We have 1.6 psychiatrists per 100,000 people in this country and less than one psychiatric bed, inpatient bed per 100,000 people. So we are resource poor in this regard. And so given what we know about care fragmentation, the patient population, and the resources available to us, these are factors that I consider when I think about what is the best model for inpatient mental health care. You all practice this, so you understand there are options, and they've been around, some of them, for a while. The first is just very basic, maybe the default if you're just thinking about how to put a formal system into place, but upskilling your team members to care for patients with psychiatric comorbidity. The consultation liaison psychiatry service model, which has been around for quite some time now. And then a newer model, the medical psychiatric unit or a complex intervention unit, MPUs or CIUs, are both options to provide care in the inpatient setting as well, perhaps a little bit newer. But if we think about the pros and cons of each, and if we think about upskilling, so this was a study out of the US, 530 some odd medicine inpatients. This group trailed around on rounds and documented for which reasons the psychiatric consult team was asked to see hospitalized medicine patients. You can see the reasons here. And if I think about our opportunities to upskill internal medicine bedside clinicians, these three sort of pop out at me. So medication review, if we engage our pharmacy colleagues to help us understand the indication side effects of antipsychotics and other medications that we as internists may not use as frequently or may not be as comfortable with, I think that's a quick win opportunity. Certainly the next two, capacity and assessing capacity, and then developing a differential diagnosis for acute altered mental status. And I think that that is just within our core as internists to be able to manage that as well. And so there are opportunities, and I suspect that if we went through our list of reasons why we consult our psychiatric colleagues, we could also pick off some of these things to upskill our clinicians around. Our current model is this: we have a consultation liaison psychiatry team that comes from our sister medical center. They're fantastic. They're helpful access because they are so busy as well, and their home institution is limited to just 1, maybe 2 days a week, and then by phone, of course. And so, this is a model that I'm very familiar with, having practiced in other medical centers. And curiously, as I was looking through the literature for this discussion, there seems to be sort of this bimodal peak in research around these models of care. So in the 90s, 80s, 90s, when this model was starting to become more popular, it had predated that, but more popular, there was a peak. And then more recently, with more contemporary models, there's a second peak that has started. But this systematic review from last year looked at the more contemporary models of CL psychiatry and actually did not find any benefits or improvement in those things that we as internists think about, so length of stay, cost of care, et cetera. But a caveat to that is that this systematic review didn't include any studies with some of the more contemporary models. So the proactive approach to consult medicine, where you seek patients that need your help, whether the team taking care of them knows that or not. And we have precedents for that in our hospital with our infectious disease team, who proactively looks for positive blood cultures. The lab reports it to them. They then review the patient's chart and offer their assistance proactively for these patients. And then I heard a bit yesterday, I was online listening to some of the talks about embedding a psychiatrist into the outpatient primary care clinic, a similar model, certainly in a hospital as large as ours. I think there's opportunity to think about that model as well, perhaps as we get a bit more mature. And then lastly, this idea of a med psych unit or a complex intervention unit. So carved out physical spaces within a hospital where psychiatric and internal medicine teams can perhaps co-manage and be on the unit at the same time. The hospital I just left, Mayo, we had just put a CIU in place about 3 years ago now. And the impetus for it was that many of our nurses were getting injured, physically injured by violent patients with behavioral dyscontrol and other diagnoses, and we needed a space that was safer. So, we deconstructed the rooms, took out things that can be thrown or torn off the wall. We had security on the unit 24/7. It was locked with restricted access, cameras in all the rooms so we could see what was happening between visits, et cetera. That's certainly a resource intense and an expensive unit to put into place. Our outcome was to look at, harm to our bedside providers. And so for that reason, the expense, of course, was worth it. But you have to look at your local environment to see what outcomes you're looking to affect and whether this is the best use of resource for you. When studied, and maybe this has to do with just being able to define metrics more clearly, but when studied, these units actually haven't shown benefits, again, in the same way, the length of stay, cost of care, those typical inpatient metrics. But perhaps, again, defining ahead of time like we did, we were looking at decreasing risk to our care providers. That was our metric, and we met that metric by building a CIU. So those are the options. I think there are questions that still remain, even though I've done this literature search and thought about the different care models that exist for psychiatric and medicine co-management in the hospital. Again, we touched on this a bit just a slide ago in terms of what what are the appropriate metrics if we think about different models of care to care for patients with psychiatric comorbidity? Are there benefits to upskilling? I didn't actually find any recent studies around this. I think people just assume that that's the right thing to do, and maybe it is, and maybe it doesn't need to be studied, but there isn't there isn't much out there. Similarly, as we spoke, there's sort of this bimodal peak of studies around the consult liaison model, and perhaps as some of these more contemporary models take off, we'll see that uptick continue to see if this is a beneficial model of care for us. And then I think we still need to refine, given how expensive it is to and how resource intense it is to build an MPU or a CIU and staff it consistently and well. I think we still need some work to define the best patient population. Again, going back to point number one, what are the appropriate metrics? What are we trying to improve with these models of care? So I presented my problem, and I'm hopeful that we can use the next, the question and answer session or dropping comments in for me online in terms of what advice you have from your own institutions, your own experience. What variables did you use to decide what model of care is best to care for the medical inpatient with psychiatric comorbidity? I would love to hear that. For those of you in the area, this is a common site here in the UAE. We're in constant build mode, and that's sort of been my last year at SSMC, is constant construction. I love building systems, and I need help with this one. So if anyone has advice, I'd appreciate it. Thank you. Thanks for your time.